So in terms of results, the 200 milligrams twice a day was associated with a better progression-free survival of 4.1 months and an overall survival nearly 16 months compared to doses that were lower than that, 100 milligrams twice a day. It was also associated with immune infiltration at cycle 1, day 15. It's also the predicted doses, basically doses exceeding 100 milligrams twice a day, are the doses that were thought to show pharmacokinetic therapeutic dose level ranges, and that's indeed what we saw in the pharmacokinetic studies. So that high dose of 200 milligrams twice a day really seems to be optimal. Having said that, we really didn't see more than just about 21% objective response rates. And in PD-1 treated melanoma patients, the bar might be a little bit higher than that, might be approaching 30%. But in those 21% of patients with partial responses, what's interesting is three of those patients were patients who had seen prior ipilimumab and nivolumab. So that means there may be a way that the addition of SX-682 is either reinvigorating an immune response from exhaustion, or it's indeed removing the immune suppressive microenvironment so that the immune system can work better. And now what we need to do is go kind of do a backfill, enrich all of those cohorts. Monotherapy, just to see on its own what the drug is doing, and then in patients who had a PD-1 response and lost it, and in patients who never had a PD-1 response, and look at the actual tissue-based mechanisms of those responses. So biomarker-driven trials is what we need for these patients who have progressed on anti-PD-1.